Bwana Peterson Wachira, karibu sana.
Asante.
It's good to have you here. Happy New Year. Every time between now and December 1st, if you see someone for the first time, it's Happy New Year.
And December 1st of 2025.
Yes.
I think it should end in February.
I
Let's rest it in February.
You guys can end it. It's okay.
But it's you're saying
Maybe we can agree on
So
March.
now we say what?
The first quarter.
The first quarter.
The first quarter, March is fair.
That's all right. First
Consensus.
Good morning.
Good
and Happy
morning.
New Year.
That's a good one. Right. It's good to have you here.
It's a pleasure for me being here, sitting with the nation fixers.
Yes.
And it's a very important conversation. I hear people say that from, was it June 20 what?
25th.
That the course of the nation changed.
Yep.
Yes.
And I think this is one of the platforms where you are really changing the conversations that are going to fix the nation. Where every morning we have a free civic education class.
We appreciate that.
You're a fixer.
Speaks well, eh?
He's a fixer.
Remember, guys, for the promo, please take that back.
He speaks very well.
He speaks well, but,
No,
he's also,
but it's a fact.
we appreciate that. But we also know you're here because you're aggrieved,
Yes.
right? And maybe that's an important place to begin the conversation.
We begin where Janet
Ameji, I was really trying to
run
run
away
that.
from this. Peterson.
Jano.
Yes.
Good girl Jano
Yeah.
is very good with quotes. Right? She looks at quotable quotes, and I know wewe pia ni msomi. So in terms of quotable quotes, you'll listen to the hints that she'll give us,
Okay.
and then she'll give us the quotes, and she'll ask us who said that. And let's see. None of us has actually heard it today.
Yeah.
Okay.
Today I was trying to be that student who's like skiving, Miss Skive.
Kuna.
The hint for this person, to make it as easy as possible, is that the current leader of that country has made huge waves by sort of like approaching presidency in a what he deems a very Pan-Africanist approach. And recently, he was at the inauguration of the president of Ghana, and he was the talk of that event, right? You think young, think vibrant African leader, 2025, think about the country, right? So he comes from that country. The quote is, "He who feeds you controls you." Who said that?
He who feeds you
Controls you.
controls you.
So the person who said that was also a president of that country many years ago. And he said this in the mid-80s. He used to say it a lot in his speeches. He was speaking to what we are grappling with now. He was basically talking about, please, let's not get addicted to aid. Let us not get comfortable with it, because we will end up having to be controlled by the people who are funding. What's that? Yes, so
first of all, I think, Peterson,
Yeah.
any idea?
country
He
first.
says the current president of that country was, showstopper in Ghana. Came in there, and I can think guns playing, people doing any.
Could that be Burkina Faso?
Burkina Faso is the country. Fantastic. Yes. And now this was also somebody who was considered one of their revolutionary presidents back in
Former
the
president
80s.
of Burkina Faso.
Former president of Burkina Faso.
Hotel in Nairobi. Oh, sorry.
Umesema?
That's a great clue, actually.
What did he say?
He said a hotel in Nairobi.
Okay. Okay. If you're not 100% sure, we can give you some time and come back to it. But
Yeah,
yes.
please do.
Where you got it.
Yeah.
Peterson.
I can say it. Or do any of you know?
Hotel in Nairobi. Westlands.
Starts with letter S.
Sankara.
Yes.
Sankara.
Thomas Sankara.
Thomas Sankara.
Said that in a speech. He who feeds you controls you. Funny that it holds true
Oh.
Yeah.
in many ways. But
Many years on.
many years on. But yes.
He who feeds you controls you.
Yes.
He who finances your health sector
Controls you.
controls you.
Very true.
Peterson,
Yes.
why are your people on strike again?
I think the real reason as to why we are going on strike is because we have people who have been put in positions of responsibility who either are inept or they are driven by selfish interest. But I think the baseline is that they are unable to do what they are supposed to do. And the reason as to why I'm saying this, because our two broad demands, one is on the side of the Social Health Authority, and the other one is about the implementation of the return to work agreement of 2024, which by the way is an order of the court. It's not only a return to work agreement. But if I start with the Social Health Authority, you know, there are some things that it's very hard to find logic in. So let me just lay some background so that we start with an understanding of why we have a Social Health Authority and Social Health Insurance. When the current government came in, the president said that we have tried to kickstart this universal health coverage severally. It has not worked. And so he said, probably we need to review the regulatory environment and come up with some laws that can be able to govern in terms of financing, in terms of how we manage that data, and how we offer services. That is why we have the Primary Healthcare Bill and Act, and the others. So, in their own wisdom, the executive and the legislature, they came up with a Social Health Insurance Act, because the insurance is the Social Health Insurance. I know sometimes it's confusing. Then, in the Social Health Insurance Act, it establishes a board that now manages this social health insurance. The work of that board is to manage 3 funds that have been established. We have the Primary Healthcare Fund, which gets its money from the Exchequer. We have the Social Health Insurance Fund, that is what we are all contributing to. Your money does not go to level 2, level 3. The money you are contributing, the 2.75%, goes to Social Health Insurance Fund, and you can only access it when you reach level 4, up to level 6. When you exhaust that, or you have an emergency, or you have a critical or chronic illness, there is another fund from Parliament, from the budget, from the Exchequer, called the Emergency, Chronic and Critical Care Fund. The work of the Social Health Insurance is to manage these funds, but the broader one is to ensure that we achieve universal health coverage. Now, what is universal health coverage and how do we measure it? There are 3 things we use to measure universal health coverage, or to know that we are achieving universal health coverage. Number 1 is, can every Kenyan, wherever they are, be able to access health services? Number 2, the accessible health services, of what quality are they? And number 3, while accessing the quality healthcare services, do they suffer from financial harm? Those are the 3 things that define universal health coverage.
Yep.
So how does the Social Health Authority then come in? They contract the facilities to ensure you get that access. They also ensure that these facilities they are contracting, they meet a checklist of the resources that should be in those facilities to guarantee the quality that is achievable at that time. Our Constitution defines that quality in terms of the highest standards of health achievable at that particular time.
Article 43.
Article 43 of the Constitution. And lastly, we pull the money together. And that is why we are deducted different amounts, so that if you are deducted more, you pay for the one who is deducted less. But then you get a basic package that is equal. That is why we pull, so that we protect each other from the financial harm. You see?
Yep.
That's a very good thing. But then when it came to the people who are supposed to implement this, the Social Health Authority, now when it comes to managing the practitioners, the caregivers, and the facilities, it provides that the Social Health Authority shall receive a list of practitioners and a list of the facilities from the regulatory bodies, because there are many. And once they receive, they have no option other than to empanel them. What is empanelment? Empanelment is just the recognition and then availing you to the public to offer that services on behalf of SHA. So when these people sat, they thought probably either they are too lazy or something, and they said, no, you know, these regulatory bodies are many, we don't want to deal with many regulatory bodies. What about we just pick one, which is Kenya Medical Practitioners and Dentists Council, which is against the Act of Parliament and the regulations. So when they picked the Kenya Medical Practitioners and Dentists Council, then that means that you can only be empaneled if you are registered by the KMPDC. What does that mean? That means that then you are not recognized in the system if you do not carry a registration of KMPDC, and so you cannot see anybody through that system. Okay. So if you are registered by the Nursing Council of Kenya, by the Clinic Officers Council, by the KMLTB, by the Pharmacy and Poisons Board, you cannot be able to see any Kenyan through the system of SHA. And so we raised a question. We said, this is not what the law says. Why so? At some point we were told, it was an executive directive that we only need one source, which is very laughable because we asked, is there a written executive order so that then we can go to court on behalf of Kenyans? And we were told it was by word of mouth. And that is why I'm saying, I think some people who are working there are inept. Okay. They basically do not understand these things. Yeah. And so clinic officers, up to date, we are unable to see Kenyans through the Social Health Authority, though we are actually the people who see almost 100% of the Kenyans. You know, the same people will tell you as a matter of referral policy that you cannot access level 4 before you go to level 2 and level 3. We are the clinicians at level 2, level 3, 100%. When you go to level 4 to level 6, in the outpatient department, we are the ones who will see you. So you cannot use your SHA there. You'll only access your SHA when you are admitted inpatient.
Okay. Let me ask a question here.
Yes.
So yesterday, not today, yesterday,
yes,
if I went to a level 2,
yes.
And what's a level 2? It's a health center.
It's a dispensary.
It's a dispensary.
A health center is level 3.
The level 3 is a health center.
Yes.
If I went to a dispensary, Kimana dispensary,
yes,
I would likely find a clinical officer.
Yes.
Now you're saying that that clinical officer cannot see me under SHA. Explain, because I'll find him. If I go and I find a clinical officer,
yes,
why can't he see me?
He's actually there. He's competent.
Right.
He has an act of parliament that allows him to practice. But then for him to see you through SHA, he has to be recognized in the system. How does he get recognized? It is through empanelment. Empanelment is uploading our list, their name, their credentials in the system, so that they can log in and see you through the system, or they can see you, and we can use the system to claim as the hospital. So you cannot recognize a practitioner before you recognize the regulator who gives them a registration certificate and a license.
Okay. So that means that at Kimana dispensary,
yes,
the clinical officer who's there is unable to log into the system.
Yes.
That's it.
So you'll have to pay cash.
So you're forced to pay cash because this person cannot log into the system and say that I have seen patient Eric.
Yes.
And I want to refer patient Eric to Oloitoktok level 4.
Yes.
Or he can say that, or he'll have to. So you're saying he can't log into. So what he'll do is he'll see you, but there'll have to be a cash.
Yes.
It'll have to be cash. And if you say, no, but surely I shouldn't be paying cash, then he, even without saying it, he's basically unable to, to Eric's point, log in
and refer you.
And refer you. So he can't
And
refer
even,
you.
But even if he refers you to level 4, who will see you in that outpatient?
The outpatient is another clinical officer.
So you go to level 4
so
and it's still
probably
another
you won't
cash.
still get the same service there. You may have to look for somewhere where you have a medical officer because they are registered by the KMPDC. And that is why we are saying it defies logic that the people seeing over 90%, anybody coming to hospital, we are the ones who see them. Then we decide whether we are treating you and you're going back home or you're getting admitted. When you get admitted, that is your first interaction with a medical officer. And that is why we are saying we are doing this for Kenyans, because we are seeing Kenyans suffering. And let me just put it into
I just
context.
have a question before you go on.
Yes.
KMPDC, why does it not have all the clinical officers registered?
And nurses.
Yes, and nurses and doctors and everybody else.
The full name for KMPDC is Kenya Medical Practitioners. That means medical officers and dentists council. So it registers the two.
Only.
Doctors
the
and
medical
dentists.
officers and the dentists.
Everybody else is locked out.
Pharmacists are registered by the Pharmacy and Poisons Board. Clinic officers by the Clinic Officers Council. Nursing Council registers nurses. We all have acts of parliament that provide for the same, but there are two that now register the facilities. We have, actually there are four. We have the KMPDC, facilities owned by dentists and medical officers. Clinic officers, the private facilities that are owned by clinic officers, which majority of level 2 and level 3 private, actually 80% are registered by the Clinic Officers Council. The Pharmacy and Poisons Board, we register the chemists and the pharmacists. The KMLTB, Kenya Medical Laboratory Technicians and Technologists Board, registers the labs.
See, that's a problem. Is it not?
Yeah.
It's not.
Too many.
No, it's too many bodies. If an executive order was given to have one
Let's even say
unifying
that
body,
that followed the due process and gone to Parliament and said, we want to consolidate all these different acts of Parliament on regulation of the health sector and create one super authority that says all health practitioners in this country, you will be registered by this one. All health facilities in this country, you will be registered and regulated by this one. Because now we are saying that there's a dispensary somewhere that is owned by a guy called Wachira that was licensed by a different entity. And there's a hospital somewhere that's owned, this hospital in Ruai, in Ruaka, that's licensed by a different entity. So even quality control is by two different entities.
No, but actually, let me tell you, if you did what you're saying, that will be quite retrogressive for two reasons. Number one, professionals, the global best standards is what we call self-regulation. Because you understand what somebody does, and the people sitting in the board, it is easier for them to understand where you are going wrong, to capacity build, and whatever else. But other than that, when it comes to the facilities, the biggest problem that we have been having under NHIF is where you have a single tire verification. And that is why we are saying we should actually have, even if we have a physiotherapy center, we should allow the physiotherapist council to register it. But then we should have a different accrediting body. We should have a two-tier accreditation or verification so that you register what you are registering, but let us have a different accreditor before it goes to SHA. Under NHIF, we had virtual facilities, a facility that you find somewhere in the computer. The certificate is there.
Kwa ground, nothing.
It is non-existent. We also had many facilities, and I had been involved in these inspections that were registered by even KMPDC. You find it is indicated level 4, but actually it's a level 3A when you go and inspect. So if we had a two-tier verification of the same, then that would not happen. And do you know that actually the law provides for that, but it is not implemented? And that was the wisdom behind the enactment of the Health Act, where then they brought into the picture the Kenya Health Professional Oversight Authority, which is supposed to supervise the mandates of these regulatory bodies. That is what it was supposed to do. And we actually proposing to Parliament, because we are proposing an amendment to actually make the Kenya Health Professional Oversight Authority a quality of care oversight authority, so that we shouldn't be taking the names of the practitioners and the facilities direct to SHA. Let the regulatory bodies register and license both the practitioner and the facility, but hand it over to KHPOA. Let KHPOA go to that facility and verify that actually this is a level 2. It has the resources for level 2, and now go and take that register and tell SHA, we have actually verified this is a good facility. Can you contract them?
So it's for ensuring accountability.
Yes. But if we go to one body, we are running back into the same problem. You'll have facilities online, but they are not on the ground, and they are receiving money, but they were there.
There's no way to streamline it even under one body. Is there no...
You can't. Because
people would almost go to what Latif and Mariam have said, which is, why not just have one and then find ways within which... Because if I hear you correctly, the reason why you're going on strike is to push for having the different accreditation. What does that process even look like?
That is not the reason as to why we are going on strike. The reason as to why we are going on strike is because we have been locked out of the system of SHA, and Kenyans are unable to access services. Kenyans are suffering. Let me just give an example. There is a life-saving procedure we call MVA. I know many people know it. So when ladies are bleeding after child loss and whatever, that is something that we even do at the health center. It is something that clinical officers do. Sometimes, if you don't do that within a certain period, you can actually lose that lady. Right now, if they don't have cash, you may have to refer them. Actually, it has been designated as something to be pre-authorized by a consultant. You'll find a consultant in a level 5, mostly. If you come from Mount Narok, where I come from, the nearest level 5 is in Nakuru. You'll have to travel 60 kilometers. Yet there is a health center around 10 kilometers from where you are, or even less, where you could have got that service. So we are going on strike because our people are suffering, because ourselves, we are unable to access the system and to be able to see them. And you know, funny enough, when we called for the first strike in January, I think it was on 14th of January, the leadership of the Council of Governors sat with the PS in the ministry at the COG, reviewed the laws, agreed that SHA is at fault, that the laws provide that clinical officers should be able to do that, wrote down a resolution and signed, directing the Social Health Authority to onboard clinical officers and their facilities. 4 weeks down the line, SHA has declined to do that.
Nothing.
Why? We need to understand why. Let's take a break. It's 29 minutes to 8. I know people like to hear the time because you're preparing and you need to get out of the house.
Yes.
It's 29 minutes to 8. This is Fixing the Nation, one conversation at a time. Eric Latif, Janet Bogua, and Mariam Bishar. This morning hosting Peterson Wachira. Peterson Wachira is the national chairman of the Kenya Union of Clinical Officers who have gone on strike. All of them. How many members do you have?
500 in public sector.
8,500 in public facilities.
Yes.
These ones you'll find them in level 2 dispensary, level 3 health center, level 4, level 5 outpatient services. These are the people who are offering those services, because if you don't get them, it's because they're on strike. Now we are live on NTV. We are also live on Nation FM. If you'd like to ask a question, we can take a couple of questions after this break. And also you can post your questions and comments on our digital platforms wherever we are live streaming. Back shortly.
So the fact that this conversation is one that did not start yesterday, but there has been consistent failures to either hold up, whether it's court orders or the government's end of the deal, is worrying, but it's a trend we've seen time and time again. Why strike now? You said, you know what, the fact that we are unable to get on SHA and to be logged on SHA and to give critical care to patients across the country is a big problem. The fact that also our return to work formula has not been honored is a big, big problem. But why the now?
Yeah, thank you. Let me first say that we really don't like striking. We are very happy sitting in the consultation rooms and alleviating the suffering of our patients. We feel very nice. That is what we swore to do. But also, there is a time when it reaches when yourself being there, you are doing a disservice to that patient. And the best you can do is go out, make things better, and allow them to come back, when then you can be able to provide the highest standards of health as envisioned in our constitution. But then, just to show you that we never wanted to go on strike, this thing started in November. And you remember, we said, why don't we just utilize the Constitution, Article 37, assemble, demonstrate, and picket. And we really picketed at the SHA offices, at the ministry offices. Nobody had us. In January, we said, okay, it seems demonstrations, they can't hear us. Probably they are deaf. If we go on strike and the patients talk, probably they'll hear. And you saw when we went on strike, in a record 3 days, we were having meetings to midnight, and they came together, signed a resolution, and they asked us, can you give us 21 days so that we can be able to implement this? And when you're talking about implementation, there is no legal framework that needs to be changed, because what we're asking for is what the law says in terms of the Social Health Authority. But also when it comes to the return to work agreement, let me just give a short background. We have been looking for the collective bargaining agreement for a long time. So from 2019, we have been going on strike. In 2021, we went on strike and the employers took us to court. The court directed us to go back to work. We went back to work. But then the court, after some time, realizing that after we went back to work, we have not been negotiating, in 2023 October, issued compelling orders to the employers, the 47 county governments and the ministry, to come to the table, negotiate and conclude a CBA. They ignored. So in 2024, we went on strike to enforce orders of the court to force them to come and negotiate. When then that continued for more than 3 months, and it's like we were not concluding, the same court then came out and gave another order and said, can you guys sit down, draft a framework with timelines on how you are going to resolve this, and come back and register it in court. So we sat down at the COG, at the ministry. We drafted a return to work agreement, which is a framework on how we are going to resolve these things. And we went back to court. And I remember the judge then, Baira Mongaya, he asked 2 questions. 1, did you enter into this agreement in good faith? And all the lawyers said, yes. The next question he asked was, are you now going to implement this, or I'm going to find you here next year?
Because now we will implement this one.
Because you didn't implement. They said, no, but it's an agreement between ourselves. And now we are here. The deadline for implementation of whatsoever was in that agreement was September 1st, 2024. When we realized it was not done in January, we went on strike to ask these guys, hey, this is not our demands. This is an agreement that we agreed as both of us. Right. And we agreed that we were going to implement. What is happening? And that is why they came to the table and said, hey guys, can you give us 21 days? We are going to implement these things. By the way, it's not a matter of negotiation now, because we already negotiated and it's in the return to work agreement. It's about the implementation. Yeah. And then after 21 days, we realize we have not moved. It is like there is no goodwill. They only come out when there is a crisis. They come and they're very nice during that time. And then when the crisis is gone, they also disappear with it. Okay. And that is why we decided maybe now it's better we stay on strike.
To engineer another crisis.
Until the things are resolved. And what we are saying, especially on the Social Health Authority, we are not even going to any meetings. We are not attending any meetings. Everything that needs to be done is done. The law is there. A resolution by the people who are supposed to give policy guidance to SHA is there, signed. And so what are we going to talk about? Let them implement. We want to see our people pre-authorizing. You know, there are so many guys with cataracts who cannot see, who are waiting for them to authorize, because 98% of cataract surgeons are clinic officers.
Peterson, I'm not understanding this issue really. Because if you're telling me that all those thousands of clinical officers in our public facilities alone are today not able to offer the service, because we are saying that the primary health care is offered primarily by clinical officers. Yes. Right? Yes. And our UHC is structured in such a way that we begin at primary level. Yes. We go to a dispensary first before we decide to go to Mama Lucy, to Bagathi, to KNH. We should go to dispensary. Yes. If this is clear to those at the Ministry of Health, to those at the Council of Governors, to those who are running the Social Health Authority, who are doctors.
Yes.
And they've been in these facilities. If it's clear, why are we here? What could this be that is making them not do it?
We are here because of cartelism.
What cartel?
You know, one day we came out as unions during Mutahikagwe's time, during Cecily's time, and we said we have cartels under NHIF and in the ministry. And I remember Mutahikagwe came out and dismissed us. But himself, on another day, he came out of the ministry, and I remember him pointing to that ministry and saying, this ministry is full of cartels. You remember him?
Yep.
And I want to inform Kenyans with clarity that the cartels that were under NHIF are alive and well. And I'm saying this because the president, at one time, he said, as long as he is the president, there won't be cartels. And I want to inform him that the cartel that was under NHIF is now alive and well under the Social Health Authority.
Okay, so let
me explain the cartel.
Let's say that there's a cartel. I want you to show me how the cartel benefits by having a clinical officer locked out of a system.
Very good. The cartel, how they benefit from this entire system is something we call monopolization of the healthcare delivery. How do they do this? They do this by ensuring that only the people that we register, and that is why we are saying KMPDC is part of the cartel, only the facilities we register can be able to receive the funds, because you have to be contracted to receive the funds, and all the patients will only come to us, whether it's the facilities that we register or it's the people that we register, irrespective of the fact that there are other people that we don't register that are allowed by law to practice that. So they use other ways other than the law, because that is what cartels do outside the law, to attract the monetary benefits to themselves only while excluding others and denying this health service or health care to the Kenyans. But also, if I'm a clinical officer, I'm a cataract surgeon, I am supposed to do a cataract surgery. 98% of those who do cataract surgery are clinical officers. I am in private sector. I approach a medical officer, can I please use your credentials? Because that is what is happening. Then they extort you. You have to pay them.
Okay. Is the cartel then doctors and dentists?
The cartel is not doctors and dentists.
If it's KMPDC, right, which currently has access to that, doctors and dentists are registered under that. Everybody else has a separate body. Is that essentially the cartel then?
No. The cartel is not the doctors and dentists.
Who is it?
The cartel is some of the people within the ministry, some of the people within SHA, some of whom we even know they own hospitals, and they are leaders of SHA, which is conflict of interest and unethical. And by the way, we are going to write to the ethics and anti-corruption. These people, some of those who own these facilities, for KMPDC, what is their interest? Their interest is that they should be able to register all the facilities so that if you want to use SHA, you come to us. Yeah. And so when you go to them, they get the money. It's not the doctor that is benefiting. But then also, if you have to see anybody through SHA, they don't care whether it's the laws you will wait to change. You have to be registered with us so that you bring that money to us. And of course, some of the people in the ministry, they benefit because they also sit in those boards.
Okay.
But also there is now the extortion thing.
Yeah.
Because if the law allows me to do something, but then I have to come to you and I have to pay you so that you can assist me to do what I'm supposed to do. And then the data that will appear at the end of the day, because that is another issue, is that I'm not the one who did that procedure. It is actually yourself. So at the end of the day, it looks like the clinical officers do not do any procedure.
I'm not getting it. I am not. How many clinical officers did you say are in public hospitals?
8,000.
Around 8,500.
8,500.
Yes.
In how many facilities? Public facilities?
Public facilities, there are so many. We have the primary care level, we have more than 4,000.
Let's even say that one clinical officer per facility.
Yes.
Which is not the case.
Yes.
But then, so we're talking about, if it's 8,500 clinical officers in public health facilities,
yes,
we're talking also about thousands of facilities.
Yes.
How would anybody benefit if I went to a government facility called Kimana Dispensary, and I went there and I found a clinical officer who is not able to attend to me through SHA unless I pay cash? How would that money benefit somebody in a cartel somewhere? I am not seeing
yes,
how denying me service, how denying you the opportunity to practice your trade is benefiting somebody somewhere.
Let me tell you how. Because then you'll be informed that, oh, you went to that public facility, yes, but there is another facility there by a doctor that actually is allowed to use.
You don't need to pay cash.
Yes, so you don't need to pay cash. So you redirect all the patients to you. That is what we are calling monopolization of healthcare delivery.
Okay, but
so
that
we bring all the patients to us.
If that other facility is owned by a doctor,
yes,
then it is not a level 2.
No, they have level 2s.
Okay.
If you have a medical clinic, even if you are a doctor, it's a level 2.
So you're saying it's doctors
yes,
and dentists who are benefiting from the cartel?
Ultimately, you see, for them, they are just, what can I say, pawns or something. The real intention is to drive everybody back to KMPDC so that they can pay there.
So let me
and these people benefit from this.
Let me ask you, so you go on strike from midnight?
Yeah, we are already on strike.
You're already on strike?
Yes.
You've talked about a lot of the issues and the grievances. So what's a timeline of, you're on strike?
Yes.
What's a timeline of what you need addressed by when and by whom? What does that timeline look like? If you were looking at best case scenario.
I think for us, the earliest they can address even today, we'll be able to go back to work, because it is not in our interest to be on strike. We only go on strike so that things can be resolved. But then, I cannot really tell, because if you have a signed document directing SHA and it never implemented in 4 weeks, I don't know if they are even willing to do it. And some of them outside there, they have been heard saying that we will never allow these guys to pre-authorize because they are going to push us out of the market. And by the way, this is not a service delivery. It's not a quality or service delivery fight. To them, it is a market fight. That we want, these guys are crowding the market. We want to remove them from the market, especially private, so that we can benefit. And that is the talks behind there.
How do we know it's not a market fight for you as well?
No, but how can it be a market fight when even in the public facilities where I don't benefit, I'm unable to see that Kenyans? You know, I can be very comfortable and say, okay, you continue using the doctor's credentials when I see these patients. After all, I don't benefit if I'm sitting in a public facility. I'll just get my salary. We can say, it's okay, you just continue with it. But then, the people who are suffering are our relatives, are ourselves, our kids. My cousin was admitted the other day somewhere in Kijabe, and we had to contribute ourselves. So at the end of the day, this is something that really affects us. Imagine losing a patient because of something that you would have been able to help, just because you had to refer them to a far-flung hospital, just because you couldn't do that. So sometimes we also turn ourselves into advocates, because it really impacts our mental health. Especially when you know I can be able to help this patient, but I have been blocked. My hands have been tied by somebody else so that I cannot be able to do this. But then when it comes to the other issues, like if you look at the CBAs, we are basically done with the CBA with the Council of Governors and the Ministry. The Ministry one we finished early December. Up to now we are still being told we are waiting for Treasury and SRC so that we can sign. And you wonder, this Treasury, I see the CS for Treasury even coming out to Barazas. How do you tell us? He has never been available since December. So we are reading ill will. There is no goodwill from the government. And that is why we have to come out and ensure that these things happen, so that when we go back, then we don't have to keep on coming out and going back. And, sometimes even Kenyans think that we are the problem. But really, I think at some point, and especially on the issue of the Social Health Authority, probably we shouldn't actually be the ones demonstrating. But I don't know. Kenyans can demonstrate for political reasons. But for some things that are very close to their hearts and to them, like health, I've never seen Kenyans coming out to demonstrate. And this is one of the things that they should. Because the fact of the matter is, the social health insurance is a very good thing. It should actually be better than the NHIF. Why aren't Kenyans enrolling into it? They are wondering if when I go to my nearest facility, I'm told that they cannot be able to use SHA. Why are you telling me to register into this thing when I'll never use it?
So let me get this. The clinical officers are on strike because the SHA system is not allowing them to log on, to see patients, and to document the patient journey on the platform.
Yes.
And this is because SHA only recognizes KMPDC.
Yes.
The Kenya Medical Practitioners and Dentists Council.
Yes.
Which licenses doctors and dentists.
Yeah.
Clinical officers are licensed by the Clinical Officers Council.
Yes.
Nurses by the Nursing Council.
Yes.
Pharmacies by Pharmacy and Poisons Board. Are we therefore saying that what grievances you're raising today are also the same grievances to be raised by nurses, by pharmacists, by technologists? Are we saying that if I went to a facility and there's a nurse in that facility, that nurse has no access to the SHA system?
The ones who need to pre-authorize.
If I went to a pharmacy and I want to use SHA, I cannot use SHA because the pharmacist has no access to the SHA system.
If you go to where you need the services of a nurse anesthetist, because for them they pre-authorize, they'll not be able to do that. They were actually on strike with us during the other time. There are many of them, they have not come out. Some of them are relying on us to resolve this mess. But actually, it is everybody else who is supposed to pre-authorize or is supposed to have a facility that is actually suffering from this.
Vincent Koech says on YouTube, Wachira is wrong. I am a nurse and I have a facility registered by KMPDC. Registration must be uniform.
But the KMPDC has arrogated upon themselves that registration by other people who are not medical officers and dentists, and it's illegal. Even myself, if I go and register with KMPDC, that facility, it will be given the SHA rights. But if the same facility is registered with the Clinical Officers Council, then they decline the same. The KMPDC Act is very clear that they are supposed to register facilities by medical officers and dentists. So any other facility, even the public facilities, they're registering by the way, it is illegal. But the problem is that they are tied with some of the senior people in the ministry at the HIP, some of them who are supposed to be guiding and advising the country also sit in these boards. And that is why there is an inherent bias when it comes to the KMPDC and most of the leaders within the ministry. And that is why we have, if you remember, there is a time we came out and said that the problem with the Ministry of Health is the homogeneous nature of its technical leadership. Because if you look at it, all the directors
are doctors.
They went to the same school. They have the same experience. They were in the same environment. So that is what they understand. So you find very different fields. Why would you have public health being directed by a medical officer? When we have people who were trained as public health officers up to the PhD level. That is one of the problems we have. And until we come out and say these things clearly and objectively, without people feeling like they are being fought, so that we separate the individuals, we separate ourselves and look at the management. Because if you are going to have one cadre that is managing health in this country, it goes without saying that at some point they'll be biased to what they know. It can be deliberate bias. Sometimes it can be just innocent because they know no other thing. Yeah. That is the environment they have been under. And that is why we have been saying that we must get to a point where then the leadership in the Ministry of Health represents the whole healthcare delivery spectrum. So that then we can have sound decisions.
Should be in that leadership.
Yes.
Right.
Peterson, thank you for joining us.
Asante sana.
We'll be following up on seeing what happens. You're on strike, what meetings you're going to have, whether this is going to be resolved as fast as possible. Because in the end, like Janet was saying, it is about the person who wakes up this morning with a headache, with a toothache, with whatever. They have malaria, they have whatever, and they need to go to a facility, and they don't find a clinical officer in that facility.
True.
And they suffer.
Yes.
It's about that person. Keep it here for more conversations. In the next hour, we talk about budget. So we are at that point. So June is coming. We shall be talking about the finance bill again. But before the finance bill, we need to start talking about the budget policy statement, what it looks like, what the government is thinking about in expenditure for the next financial year. And we will be joined by Cuba Houghton, who is a budget expert, and he'll be joining us for the next hour. It's up 2 minutes after 8. Good morning. This is Fixing the Nation, one conversation at a time.